And we'll make sure this session we won't try to get sleepy or anything. So yeah, without any further delay, let's start this session. Um, just a second, I'll share a PPT here. So I think before going ahead, even I would like to give a brief intro. As everyone know, my name is Lalit, and I work with the facilitation team of Pallium India. And I have been here for past 1.5 years, and I specifically work in the southern region. I work as a southern facilitator, and what we do as a facilitation team is what we are trying, or what we will understand today through organizing palliative care services. So I think by definition, palliative care is an holistic approach for all individuals across all age groups, where we alleviate their serious health sufferings. Holistic approach being covering their psychosocial, psychological, physical care, socio-economical care, as well as spiritual care. To understand this in a broader context, we would be looking into the WHO palliative care triangle. You see, there are three major components here. First being education. Education has certain limitations. I would say palliative care has certain barriers and limitations which can be only overcome, through educational activities. Majorly due to lack of awareness among professionals, administrators, and majorly public. I think since public is majorly unaware about this domain, I think the demand for services doesn't arise. I think when the public is aware about this domain, that's when the administrators think to act on it. The second being drug availability. Pain relief plays a major role in palliative care, and for that, availability and accessibility of pain relief medicine is paramount. And morphine is a mainstay in this domain. In Indian context, I think the amendment with the amendments of NDPS rules in 2014, an organization or a medical practitioner can stock and dispense opioids with certain conditions as per these amendments, which we will be discussing further ahead. Third being the policy. Uh, Around the world, as well as in India, palliative care came into being because of an individual initiative or initiative taken by non-government organization. However, to achieve a national coverage, the palliative care services needs to be included into the general healthcare delivery system. What would this do? This would help us in identifying the major barriers that the existing healthcare system face, and the areas that we need to work on improving these areas and bridging this gap to our last mile beneficiary, and beneficiary being the patient here. Um, any budding nation or any organization should have a palliative care policy which would help them to, I would say, bring into standards to the rest of the world. I think that's how we can bring in systemic changes, be it on a national level, be it to an community level, right? Uh, to understand more about palliative care in Indian context, is the palliative care services is being provided or is being provided in three major categories. First one being the standalone hospice or a palliative care center, a department within a hospital. This hospital can be a government hospital, a charitable one, or a for-profit organization. And the third being community-based home care. We'll understand each of these categories in a detailed manner. Um, right here that you see, I would say is an example of standalone hospices, because this particular, I would say, infrastructure or this organization, they specifically cater to and they specifically provide palliative care services that focuses on, I would say, pain and symptom management, and primarily focusing on improving quality of life for patient as well as their family members. Um, so the hospice, there is a major difference between an hospice care and a palliative care center. A hospice care is given to the patients when they have somewhere between 6 to 8 months to live, and palliative care is given to the patients at the time of diagnosis. So these are the few example of standalone hospices across India. The second being within a hospital. This right here photo is an example of a government hospital in Arunachal Pradesh, where a palliative care unit, which acts as a ward or a hospice center as and when required. The third being the community model. I think this third model is the sort of palliative care services which is given as a home care delivery through community. There is a major difference between the regular home care and the community-based home care that we provide. In this context, if we take macro as the tertiary care centers here, they get bigger and bigger every day, and the micro component, that being the patient here, they are not able to reach to this tertiary care centers. This crucial gap acts as a major hindrances for the beneficiaries. I think this major component is bridged by the community that we call as a meso model. And this particular MISO model, I think you can see it in actual play in Kerala, which we also call as the Kerala-based community model, because they have effectively utilized the community-based palliative care model, which makes the services sustainable as well as not dependent on any specific organization. Kerala has effectively done it, this palliative care model, which doesn't, I would say, it can't be replicated across India, but this is one such example which we can try to replicate in limited capability or howsoever we can in other areas, right? Now, by community level, what do we mean? I think there are major challenges that patient faces when they go through serious health sufferings, right? And I think not all these challenges can be, addressed by a specific hospital or an organization. That's where the community comes into play, where majorly these challenges can be, I would say, solved at a community level itself. And by community, what do we mean? I would say, community would be a group of volunteers or one volunteer who play a major role in bridging this gap, right? I would say, what is the role of my volunteer? This GIF rightly represents, the role that they play in the scheme of things. We'd be fool not to use this social capital that stays right behind our eyes. Right. So yes, there are limitations to the volunteers, but I think the gap that they bridge is far more beneficiary to the patients than I mean, when it's not there, right? Um, in such case, I would like to give you an example of one of our volunteers, that is story of Mr. K.M. Nair. Uh, he is a 70-year-old gentleman, uh, joined the army at the age of 17, and after serving a distinguished career, he retired in 1992. Um, he came to he came in touch with Pallium India as a caregiver to his wife, who was then 45 years old and diagnosed with stage 3 cancer. And throughout her time, he was her caregiver during that period. And unfortunately, in November 2004, she expired. But since then, Nair Uncle has been part of Pallium India as a volunteer across so many years, and he has been volunteering in his limited capability. And that is what I would say is the spirit that a volunteer requires, right? Whenever to a limited capability, whatever you can do, you provide that service, you volunteer for that, right? So I think that's the spirit that I would say every volunteer should have. Now, Coming to our model, what do we follow here? And I think most of you post completing the training, hopefully you visit Thiruvananthapuram, and this is what we would like to demonstrate to any of our stakeholders. We demonstrate our model. There is a visit to the Trivandrum Institute of Palliative Sciences where they understand what we do. They get hands-on training. They look after our services that are being provided through our home care team, through our social as well as community mobilization teams. Um, Suppose that um, we educate them through our online and on-site training programs, through our educational wings, that is TIPS. And these foundation training programs are quite economical and are effective in providing, um, excuse me, they are effective in providing, I would say, an overall understanding about what the palliative care is. And I think we have quite a number of alumni from TIPS, be it our foundation program for doctors, nurses, physiotherapists, volunteers, etc. Then the facilitation. The team that I work in, what do we do? We help, we do the advocacy and promotion activities that are required for palliative care. We carry out government programs. We help out NHMs, National Health Missions, to implement their policies. We catalyze new palliative care centers for government as well as private organizations. There is opioid accessibility. Opioid accessibility plays a crucial role. We help organizations in getting their, I would say, RMI license, or for practitioners, RMP. And many state administrators are not very much aware about the amendments that are made to the Narcotic Drugs and Psychotropic Substance Act, right? So we help them, we work closely with the drug administration of the respective states. Then we help out state governments in drafting their policy. Pallium India played a crucial role in drafting the Tamil Nadu Palliative Care Policy or the Kerala State Palliative Care Policy, and even the National Palliative Care Policy, which India has. Then the community engagement activities, the link center model that you see in Pallium India, or the community model that you see in Pallium India, is something we try to do with our stakeholders in their locations, where geography is not a limitation. We try to pilot it somewhere where we see an effective outcome of this service. I would say when you come to home India, I'm sorry, Pallium India, within the demonstration model, you go to a home visit. We reach to a home visits where geography is not an issue, landscape is not an issue. Link centers, and this is what our community model is. This plays a crucial role in connecting us with the community. This link center acts as the bridge where the volunteers play a crucial role in connecting us with the community on various levels. And we are reaching where they are at their own comfort, at their own home, and relieving them of their pain and helping them out. Also, we rehabilitate them at their own home with the limited resources that we have. We try to get creative, and the rehabilitation care is given to them at their home. And it's not just medicines. With the help of our community as well as social work team, along with the volunteers, we provide food too to the needy patients, because when a family is, I would say, when an individual is going through a serious health suffering, it's not just him, it's the family that gets affected, right? So we try to cover all the areas, and we try to take care of their family. Sorry. Additionally, Pallium India has its own telehealth services, which works throughout Monday to Saturday working hours, and we try to cover all the major languages that we have. We have a directory on our website which has list of palliative care centers across India. And hopefully, if do visit our website, go to the directory. If there are any palliative care centers that you know of, do inform us. We'd like to keep our directory as updated as we can. This helps our beneficiaries to reach out to their nearest palliative care centers. Um, Now, coming to the facilitation division exclusively on what our objectives are and how we will help you out in organizing a palliative care service, right? We facilitate, as mentioned earlier, we facilitate new palliative care centers. We help you out in, I would say, post completing your virtual educations. How do you get a hands-on training experience? You can't come all the way to Thiruvananthapuram. We connect you with the nearest palliative care centers who are our hands-on training partners, where you get this. So on those areas, then post completing your education, be it on the implementation level, how do we implement this? How do a new palliative care center come into being? We help you with that. We provide you budgeting proposals. We connect you with the private and public stakeholders. Um, Apart from that, we help you out with opioid availability and legal frameworks that goes along with it. We help you out in with procuring licenses. If the organization is into community-based model or the volunteer mobilization activity, we'll help them out in providing volunteer training programs, which is entirely free of cost in language specific model, right? This volunteer training programs are conducted through language specific for the specific requirement of those volunteers. And we are not just limited to facilitating organizations, we help out medical institutes in upskilling their staff as well, right? We take what Pallium India does in Kerala to the rest of the world. And I am one of such facilitator working out of South, and there are facilitators across India. And as I said, the mode of delivery, government, charitable, private or for profit, and the sustainable model being the community model. Um, to show few of our works that we have done across India. This is a district hospital in Namchi where there is a dedicated palliative care unit where our Northeast coordinator has worked effectively. Um, this is a health and wellness center in Imphal where the nurse is a Nightingale Award winner. And so yeah, and this is a charitable service known as Seats Charitable Center, which provides palliative care services in Tenkasi, which is near the southernmost part of Tamil Nadu, and they reach out to individuals on their capacity and provide charitable care service, palliative care, as well as food kits or major essentials that is required by patients or their families. Another charitable center in Northeast that you can see, Shalom Rehab Center. And I would say private or for-profit organizations, Atulya Assisted Living. If you are somewhere in the south, this is something that you might have heard a lot. Atulya Assisted Living is one of such private organization which does provide palliative care for profit purposes, right? And there are these different models that are carried out by various organizations which we help with, right? Which we help them establish in various capabilities. Then, for an organization, I think once we work with them on what sort of service or what sort of mode they will be providing their services in, there are certain essentials that a palliative care organization would need, and there are these audit tools where Part A is essential for an organization to have to, I would say, to provide palliative care services. And there is Part B, which is desirables, which are regular requirements. Once the organization is set up and once the delivery service is set up, then it can be built upon. Uh, I would say we would be sharing. You can either this is the PDF that is available on website. We'll be sharing this library with you, so you can download this essential or this audit tool for your own respective centers. Now there are, I would say, even though we work with several organizations, be it on various levels, there are quite a number of challenges that we face, right? Some of those challenges are the myths around palliative care, that is only specific to cancer patients, and rest of the non-cancer patients or the non-communicable diseases take a back seat. And most of the private organizations have this understanding that it's not a very lucrative business, it's not a money-making model. I think the private organizations have not effectively used, I would say, economical model to provide these services, right? And most of these organizations wants to play safe, because if you are procuring opioids, there are certain administrative processes that you have to go through, and also there are certain records that you have to maintain, because you are answerable to I would say answerable to drug administration. So there comes a responsibility with it. So not getting into this is something that organizations think as a play safe. Then comes the more crucial aspect of it is an inadequate knowledge, because since there is not much of knowledge regarding this particular domain, most of them think it's not a lucrative business, and hence the multiplier effect that he has. Um, when you cross that, then there are limited human resources who are trained in palliative care, be it nurses, be it doctors, be it social workers, psychologists, etc. And even if we come across all this, then I think within an hospital, the referral system plays as a major blocker in availing this palliative care services. Because once a doctor is asked to refer, I think based on an economic model, their calculations are entirely different, so that takes a beating. Then most of the private organizations are hesitant to share their good practices, even though they are rendering quite a good service. I think to stay exclusive, these organizations are hesitant to share their practices. Apart from that, I think the major barrier that we face on an administrative level, on a policy level, is the lack of awareness of the domain itself among the medical fraternity, the general public, and the government officials. I think the government officials play a crucial role in taking this on a more national scale and implementing it across various states. And second would be the lack of knowledge on government programs, because India has a national palliative care policy which was brought in 2013. We call it as NPPC. Um, it is implemented with the help of National Health Mission of respective states. And post that policy was brought in, I think Kerala as well as Tamil Nadu has their respective own state palliative care policies. Kerala has effectively implemented. I think we are helping out rest of the states in effectively implementing it, because yes, we do have a national palliative care policy, but I think when you visit most of our government hospitals, it's very tough to find a department of palliative care or palliative care services that are being rendered, right? And then comes the third major role, the information and opioid accessibility. We work with the drug administration of respective states, because earlier the NDPS rules of 1984 or 85 were quite stringent, and the organizations had to go through various processes to stock and dispense opioids. But after working so hard with the lawmakers, um, the 2014 amendments played a major relaxer in bringing ease of access to procure these opioids or these essential narcotic drugs. Right now, we have a single authority, that is the drug administrator of the respective state, which who provides recognized medical institute certificate, which we call RMI, to respective organization with a 3-year timeline to stock and dispense opioids, and they are the sole authority who can do that. But not many drug controllers or the administrators are implementing the 2014 amendments, and still many states or the organizations are following the old amendment rules, which certainly creates a lack of, I would say, which creates an atmosphere of I would say tiredness in procuring this opioids and then prescribing it, then stocking it, and because of the old stringent processes, we help in institutes in getting this RMIs, be it from the applying stage to finally procuring it from the drug administration. We are there throughout. These are the few barriers that we face through, and then there are always regional barriers, because you see, if you are in south of India, specifically Kerala, there are volunteers, there are state respective policies, and the patients get a palliative care services at their home. But that's not the case when you come just to the nearest state, that is Tamil Nadu, or when you go above, bit above, be it Orissa, be it Maharashtra, the kind of services that one gets, it's quite different to what another state gets, right? So we are trying to bridge this gap into an to our capability. We are trying to I would say demystify the myths that are around palliative care. There are state-specific myths. For example, in Tamil Nadu, most of the palliative care services are being provided through charitable care centers, charitable services, and patients believe, if it's a charitable service, it's not for us. We have money, we would like to go and spend it, and we would see what are the effective outcome. If it's a charitable service, they believe it's not for them, it's for downtrodden, or they are not, they have still time. But I think that's an entirely myth built around that, right? So we fight against this sort of myths, and we try to break this bubble. And we are slowly and steadily reaching there. And so yeah, I would like to show you our team that is working across India, playing a small yet crucial role in implementing this particular, taking our work across India, right? I'm based out in Chennai. Similarly, there are several other individuals who are based out in Northeast, Central India, Northern regions, etc. So yeah, thank you very much for giving your time. Uh, Now, I would like to hear from you, your thoughts on this, your questions, anything. Please feel free to uh, ask questions. Yeah.
Thank you, Lalit. So there were few questions in the chat box. I can read that for you now. So Dr. Dilip was asking, in Maharashtra, palliative care is in the very primitive stage, and I'm looking forward to do in this area for Mumbai and Maharashtra first, and want
Hmm.
to have some serious discussion with senior team members.
Yeah. Sorry. So I think it's quite, I'm glad to know that you are interested. I'll connect you with the, hello? Hello?
Yes,
Hello?
please go ahead,
Yeah,
Lalit.
yeah. So what I'll do is I'll connect you with our regional coordinator who is based out in Pune. I think she would help you out in understanding understanding context of palliative care situation in Maharashtra. Dr. Hasmat, if you can just, I would say, in chat box, let me just share our. Um, so I'm sorry, I didn't get the respective individual's name.
Dr. Dilip Pawar.
Dr.
Dr.
Dilip
Dilip, would
Pawar.
you like to unmute and speak?
Yeah. So, good afternoon and thanks for the session. So, I
Yes.
myself an oncologist and worked in a lot of research area in oncology.
Yes,
But
sir.
of late, when I was doing a lot of medical camps, one of my domain was prevention of cancers. So
Hmm.
many times we are looking that patients were reporting almost like 70% of the patients report which are in the advanced stage, around third stage and fourth stage, and
Yes.
palliative care is almost missing. So that was my earlier mission, that we have done a lot of camps where we screen more than a few lakhs patient for early detection of cancers and all. But then I felt while doing this, the palliative care is almost missing. Like a lot of
Hmm.
patients just suffer at home, and availability of medicine is one of the very big issue. People travel unnecessarily long distance travel. I work with Tata Cancer, So just travel few thousands of kilometer and then realize that nothing can be done. And upfront people say nothing can be done, and the
Yes,
patient
sir.
goes back suffering. So it is very painful to see all these things. So I'm slightly shifting my focus along with the preventive medicine to palliative care. So the plan is little big one, like what we are embarking, how we can start, and we are doing small steps ahead. So that was the reason. One, of course, if you already have such a rich experience and domain, so it's always better to take help of someone who have already been in this field for long, and that's why I wanted to have this meeting. That was my first question.
Yeah. No, sir, I think, collaborating with someone like you, I think that is something we look forward to, because you are the ones who give us an actual context on how the things are at ground. I would say, sir, with respect to the context of Maharashtra, I have shared the contact detail in the chat box of our regional coordinator who is in Maharashtra. I think someone else asked about Goa too. She is based out in Pune, and she's the coordinator for Goa as well as Maharashtra. Do reach out to her, sir. And I think there are interesting work that is being done on a community level, on an institutional level, as well as with the NHMs in Maharashtra. She would A discussion with her and a meeting with her would be of a great outcome, is what I can understand. So hopefully you reach out to her soon, and I too will intimidate her regarding your request, sir.
Okay.
Thank you,
My
Dr.
second,
Lal.
yeah, my second question was
Yeah, yeah.
because we I've gone through this national policy and I'm looking at it in more detail. Uh,
Hmm.
so you said we have a separate policy for Kerala and Tamil Nadu. You just mentioned. So I
Yeah.
just posed a question: what is the tremendous benefit having a separate policy? Because I understand the one we don't have in Maharashtra as on date. And
Hmm.
I have good connect with the health minister because I was with the health minister for one or two camps recently. So 2 days
Understood, sir.
back, I was with health minister. So is there a big advantage, or that's why I could not get much understanding on that, so
Yes,
that
sir.
I can talk to the health minister itself.
No, sir. I think the national palliative care policy that we have, I think that I would say constitutes on what all are the areas that we cover, and how the training programs, be it the financial aspect of it, and how they are going to implement it on an administrative level. But the state respective palliative care policies, for example, the Kerala I think Kerala state had the first state independent palliative care policy in 2008. That was used as a reference to draft the national palliative care policy. And again in 2019, I think the policy was revised in Kerala. So I think there are geographical as well as landscape difference what we have, and the amount of accessibility of services. So each of the state in its respective own, through its administrative wings, through the on ground presence that they have drafted their policies. For example, um, in Kerala, I think the local panchayat has 70% of administrative, I would say, power with them, and 30% rests with the state government. So each panchayat has a palliative care unit in Kerala, and through this each there is a dedicated doctor, nurse, and and a community mobilizer along with this unit. So they play a crucial role in connecting with the community and bringing them back. So this sort of service is not replicable in Tamil Nadu. In Tamil Nadu, if you see, there are health and primary healthcare centers across the ruralist of villages, and they are very well connected to the nearest district hospitals than to the tertiary care centers. But I think that is not similar to the case of Orissa or Madhya Pradesh or Maharashtra. So it's quite state specific, but I think it's a list of plan that own state comes through. I think with the services that they have and how they want to implement it. For example, the Kerala policy that was constituted, it was constituted in a mind in which community plays a major role. But similarly, in Tamil Nadu, if you see, the community-led model is somewhat, it is in a backseat, but majorly it's morely on an institutional level. I think recently is when the community-based model has been brought in. Similarly, I would say, to cover these differences, Each state are working through that. And I think for a reference, we can share the palliative care policies of the respective states. That would help in understanding. I think we are working actively with even Maharashtra. So I think it's up to the administrators now on how to, intervene and implement or a constitute or draw up a policy as the state requires. So that sort of a
Yeah.
major difference
So
lies,
thanks so
Dr.
much.
Dilip.
So definitely, if your team can send me, or if the website link of Kerala or Tamil Nadu, I can download those policies. And second,
Yeah,
you said that you are already working along with Maharashtra state with someone, or it's a very
yeah.
preliminary stage.
So no, actually, we have signed MOU with the NHM of Maharashtra in rendering palliative care services, and one of the coordinator who is working there, uh, she's working actively, I think, with the primary healthcare centers. So I think for more details and how the work is going on ground, do reach out to her. She would be able to provide you more detailed context on what's happening in Maharashtra.
But at policy level, something has happened in Maharashtra.
No. I think on a policy level, it's in very nascent stage.
Yeah,
We have signed an MOU though. We are working with the NHM on improving their services, but on a policy level, yes, it's in very nascent stage.
yeah. Okay. Thanks. So maybe offline, because a lot of other people may have question. So
Yes,
offline, that's what I said. I want to have a couple of serious discussion, and maybe I'll visit Trivandrum
yes, sir.
shortly once this is over, and then I can take offline a lot of other discussion. Thank you so much.
Thank you, thank you. It was nice talking to you, Dr. Dilip.
So there was one question in the chat box regarding who's the coordinator, regional coordinator for Goa. So it is
Yeah,
Miss Sunanda, and I think mainly in this batch, Lalit, we see that there are more participants from Goa, around 46 doctors that
okay,
enrolled from Goa. So yes, you can reach out to Miss Sunanda, and hopefully, I think she'll be joining for the session which is upcoming on July 22nd, which is on opioid availability. You can have an interaction with her if you have more questions regarding the same.
yeah,
So she's always there, and I think Sangeet has posted the message in the WhatsApp group also. The contact numbers of all the regional coordinators have been posted. So based on the regions, you can reach out to them directly via WhatsApp. I hope that
sounds
helps.
good. Yeah, and
Any more
uh,
questions?
any more questions with respect to? Um,
Participants feel free to ask your questions because this is the only opportunity where the coordinators from the national facilitation team also joins us, and I know there will be a lot of practical issues when it is easy to get certified, to get the certification after finishing the course, but when you go back and try to practice, definitely there will be a lot of challenges. So I think if you have any questions, you can ask Lalit now, and he'll be able to help you on that.
So sorry, I have one more question, which maybe again offline we can take, because I'm shortly some hospitals. To start with one hospital where we will need support for getting all these licenses and other stuff. So I guess there's
hmm.
some separate session for that.
Yes, sir. I think as Dr. Ashwin Farana mentioned, there is an opioid availability session, and I think that is led by Sunanda herself. And yeah, if at all there is any assistance required in that, you can reach out to her and she'll explain you with the process. But again, just to re-emphasize on this point to all the medical practitioners here, we have NDPS amendments that was brought in 2014, and that allows the organizations to stock and dispense opioids. So if you have an RMI, you are I would say, eligible to dispense, stock, and prescribe opioids. And drug administration of the respective state is the only sole authority that is required to intervene. Mm, so the relevant practices, many state respective organizations are not following these new amendments, but yeah, okay.
So any MD can prescribe opioids, or anybody who
Yeah,
has MD medicine, or no, they can't.
No, sir. I think the minimum requirement for prescribing opioids is an MBBS trained, and also who is a palliative care trained physician who has a certification in palliative care. Along with that, if he's, you have to be, I think the registration certificates and so on, it's required. And there are two forms which the drug administration provides. We have to fill out that form. Along with that, once we submit it, I think after the regular inspection, the drug administration provides an RMI certificate too.
Thank you, Dr. Dilip, for bringing in that question. So, to add on to that, yes, the NDPS Amendment Act says that a doctor, a registered medical practitioner, has to be trained in pain relief and palliative care to prescribe opioids. So, after you finish this course and you get the certification, you will be able to prescribe. But then you should have a recognized medical institution where you can procure opioids, keep oral morphine, and then prescribe it. So for that purpose, you need to understand how to organize it and all of that. So this is entirely covered in the upcoming session on July 22nd, that is on opioid availability, where Dr. Sunil will be talking about all these aspects in detail, like after you finish the course, how you have to go and apply, what are the forms that are need to be filled, and what are the prerequisites that you need to have to apply as a recognized medical institution. And all these aspects definitely will be covered in detail, and it is the most interactive session that we are planning for this batch especially. And that's the reason why we have, like, posted flyers mentioning the importance of that session, because the essence of the session is so good and we want all of you to attend it. Though it is the last session, we want all of you to attend it so that you will get to know how you can practice when you go back with the certification. And recently I had posted a quest to add on to that. Recently I had posted a Google form in the group this afternoon, where you can click and you can post all your questions, whatever doubts and concerns that you have, you can post it there. And Dr. Sunil, along with the facilitation team that would be joining that particular day with Shalini ma'am as well as Sunanda ma'am, they will be able to take up all of this and will be able to help you all a lot. So I want you all to make use of that opportunity and also post your questions on this. So yes, Dr. Dilip, you will get a clear idea of it in the last session.
Yeah, thank you so much. So definitely, we need more help, and possibly so wanted to visit the Trivandrum Center. So I'm not sure. Offline, I should just come, or I should do the fellowship program and come. So that I'll discuss separately.
Thank you.
you.
Thank you, Doctor. Thank you. Any more questions from the participants?
Mm. So,
So if there are no
yes.
more questions, yes, Sangeet, I don't think there are any more questions in the chat box, right? And Dr. Dilip had requested for a PDF that you had shared, Lalit, during the session. So
Yes, I'll share the respective link with Sangeet. Sangeet can post it in the group.
Okay. The PDF will be posted in the IAPA platform.
Yeah.
thank you, Lalit.
So thank you,
Yes.
Lalit, for the wonderful session. Thank you for being here. Thank you, Dr. Hashman, for the facilitating the entire sessions. Thank you all for participating in the sessions very well. Thank you. Let's see you in the next sessions. Bye.
Bye. Have a good day.